We are live.
Welcome everyone to the Journal Club meeting season 4 jointly hosted by MOS and BOA. Today we are talking about a refractive surgery topic, a topic about presbyopia, monovision, laser vision correction. And today we have stalwart refractive surgeons today talking about it and deliberating about it. It will be definitely a great discussion. Dr. Rohit Shetty, because of his personal reasons, could not join the meeting, but nevertheless, Dr. Praveen Krishna and Dr. Vardhaman Kankaria are there today with us to discuss further. I invite the MOS president to do the introductory remarks. Dr. Suresh Thorat, sir.
Thank you, Vishal. Thank you, Vishal Bhai, and General Club Committee for coming out with such a important issue and aspect in the laser refractive surgery. On behalf of MOS, I welcome you all. We are really honored to host our distinguished experts who are leading figures in the refractive surgery. They are leaders in refractive fields. They have not only pushed the boundaries of innovations, but have also inspired a new generation to follow their footsteps. Actually, words fall short to describe their work. Friends, as an Indian, we are proud of Dr. Rohit Shetty, Dr. Praveen Krishna, and Dr. Vardhaman Kankaria. I'm sure this is going to be a real academic treat from these two titans in the field of the refractive surgery. Thank you all faculties, presenters, and moderators for your valuable time. Back to you, Vaishal.
So, without further ado, we ask Dr. Parul Deshpande to open the meeting with the introduction of the faculty.
Thanks, Vaishal. So today we have the meeting on monovision, laser vision correction. And the speaker is Dr. Pratibha Khandare from Srimati Kashibai Navle Medical College. And the moderator is Dr. Bhakti Tipse, who is the associate professor at Kashibai Navle Medical College and a cornea specialist. With me, the moderation will be done by the Journal Club members, that is Dr. Zain and Dr. Neeraj. So we have our eminent panelists, Dr. Vardhaman and Dr. Praveen Krishna Vaddavalli. So we do not need any introduction of both, but as we know, Dr. Praveen Krishna Vaddavalli, he is an expert in his field. He is not only a good human being, but he has been an inspiring laser surgeon for all the cornea fellows that have come out from LVP or from the other institutes. He's also now into AI. So he is, I think, probably the network director of the LVPI and is looking after the AI part of it also. Now we have Dr. Vardhaman Kankaria, who is heading the Asian Eye Institute at Pune. And he has been the previous president of MOS. And he's also class apart in his laser refractive surgery experience. So with this, I think we would like to move ahead to the main Journal Club article. So I would request Dr. Pratibha Khandare to share her presentation and start with the presentation. Dr. Praveen will join a little shortly because he was traveling. Pratibha, share your presentation.
Yes, ma'am. Is it visible, ma'am? Hello?
Yeah.
Yes, visible and you're
Should I
audible.
go for slides?
Go ahead. Go ahead.
Pratibha, you can start from the
You
first
can
slide.
start the presentation. Start the presentation.
Okay. So, good evening, all respected faculty. I'm Dr. Pratibha Khandare, Junior Resident 3 from Srimati Kashibai Navle Medical College, Pune. The article for today's journal club is Reasons for Retreatment Following Monovision Laser Refractive Surgery. The overview of the presentation include introduction, purpose, methods, research, discussion, and critical appraisal. Introduction. Laser refractive surgeries are on rise over past few decades. However, the primary motive of these surgeries to remain glass-free is not served in presbyopic age group. Hence, a novel approach of monovision in laser refractive surgery is on rise, considering large number of patients demanding refractive surgery in presbyopic age group. Chances of retreatment following monovision refractive surgery still remains a concern in order to achieve good patient satisfaction. There are not many articles with large number of study groups. Monovision is a unique approach that corrects one eye for distance vision and other eye for near vision. It aims to reduce or eliminate the need for reading glasses in patients with presbyopia. Some patients experience dissatisfaction with quality of vision or may not adapt well to induced anisometropia, leading to potential need for retreatment following monovision laser refractive surgery. Aim is to study the incidence of causes of retreatment following monovision laser refractive surgery. Materials and methods. It is a retrospective study. Study duration is patient undergoing monovision LASIK or PRK over a period of 10 years that includes 2012 to 2022. Choice of PRK and LASIK was decided based on corneal thickness, refractive error, and lifestyle considerations. Study location was Care Vision Laser Centers, Israel. Age inclusion criteria includes age between 36 to 60 years, stable refraction for at least 12 months, intraocular pressure less than 21 mmHg, of contact lenses, that is more than 2 weeks for rigid contact lenses and more than 4 days for soft contact lenses. No history of previous ocular surgery was there. Exclusion criteria not specified in the study. Following pre-operative evaluation was done that includes complete history, visual acuity, manifest refraction that includes sphere, cylinder, and spherical equivalence, uncorrected distance visual acuity, corrected distance visual acuity, operative near vision capabilities, slit lamp examination, corneal topography, corneal thickness, sensory testing on at least 2 separate occasions to identify dominant eye. Patients are routinely informed that greater tolerance to monovision can delay the need for reading glasses as their accommodative ability declines with age. Following data collection done for all the patients preoperatively and postoperatively. Preoperatively includes age, gender, manifest refraction, uncorrected distance visual acuity, corrected distance visual acuity. And postoperatively, it was manifest refraction, uncorrected distance visual acuity, corrected distance visual acuity. In addition, reason for retreatment were documented. Surgical techniques. Topical anesthetics, benoxinate hydrochloride, 0.4% used, eyelid speculum applied, flap created with microkeratome, thickness plate of 90 microns in LASIK or epithelial remove PRK. Wavelight X500 excimer laser system, Alcon was used. In PRK, a sponge soaked with 0.02% mitomycin C was placed on stroma for 20 to 60 seconds depending on the amount of ablation, and a contact lens was placed. Post-operative medications include moxifloxacin 0.5% 4 times daily, dexamethasone 0.1% either twice or 4 times daily. Artificial tears. Patients were examined on first day, 1 week, and 1, 3, and 6 months post-operatively, and thereafter as needed. Now, choice of surgery between PRK and LASIK. PRK is preferred for mostly thin corneas and deep set eyes. LASIK is preferred for adequate corneal thickness because it gives faster visual recovery and less post-operative discomfort. Patients were encouraged to return for examination, number 1, if the vision declined after surgery, if the desired refractive target was not met. The inclusion criteria for retreatment was at least 3 and 6 months following LASIK and PRK respectively with stable refraction at 2 separate visits. Retreatment exclusion criteria was not considered in this study. Statistical analysis was done for continuous data and categorical variables. For continuous data, students t-test for normally distributed variables and Kruskal-Wallis test for non-parametric variables. And for analysis of categorical variable, the chi-square or Fisher-exact test was used. If applicable, odds ratio values were calculated. A two-sided p-value less than 0.5 was considered statistically significant. Data was analyzed with Minitab 21. Now results. The mean age was 46.4 with 5.1 of standard deviation, which include 58.6% of male and 41.4% of female. Right eye was dominant for 62.8% patients and left eye was dominant for 37.2%. Out of that, 71 underwent LASIK and 29% patient underwent PRK. The rate of retreatment was higher in eyes targeted for distance correction, which was 1.70% compared to those targeted for near vision correction, which was 0.87%. There was a statistically significant increase in likelihood of retreatment for the distant targeted eyes in patients with monovision compared to patients without monovision. This graph was taken from article which shows percentage of eyes undergoing retreatment. In this study, this particular segment of non-monovision was not included in the study. Now, the reasons for retreatment in the distant targeted eyes in patients with monovision, which was more common myopic undercorrection, that is 45.2%, followed by myopic regression, which was 19.4%. The other reasons were myopic overcorrection, hyperopic regression, astigmatic undercorrection, regression of astigmatism. Now, the reason for retreatment in the near targeted eyes in patients with monovision, which was more common, was excessive myopia, followed by on-target monovision reversal, which was 25%. Other reasons were insufficient myopia, monovision reversal, de novo astigmatism, monovision reversal, and de novo astigmatism aiming for near vision again. Now, comparison of retreatment rates. It was more for more distant targeted eyes, which was 1.7% compared to near targeted eyes, which was 0.87%, with a p-value of 0.02. When comparing to patients without monovision aiming for emmetropia in both eyes, the retreatment rate during the same period was 0.8%. A statistically significant increased likelihood of retreatment was observed for distant targeted eyes in patients with monovision compared to patients without monovision. Conversely, no significant difference was found for near targeted eyes when compared to patients without monovision. Now, according to our study, retreatment rates of eyes targeted for distance is more, that was 0.84% compared to eyes targeted for near, 0.44%. Studies with similar findings from Braun EH and IUB-EMG. The reasons for retreatment rates being more in distant targeted eyes compared to near targeted eyes could be minus 1.25 to minus 1.50 for near vision targeted eyes, has minimum effect on the stereo vision and reasonable working level of spectacle independence provided distant targeted eyes obtains excellent uncorrected distance visual acuity. The study has a good sample size compared to other similar studies. Sample size in this article was number of patients 1,847, whereas in the study of Braun EH it was 284, and in the study of Jain yes it was 144. The risk factor for retreatment in the following studies were age, males, astigmatism, hyperopia, undesirable post-operative outcome. However, according to a study conducted by Jain, the post-operative patient's satisfaction had no association with gender, age, laterality of treatment, or surgery type, that was LASIK or PRK. Suboptimal near vision appears to exert a consistently lesser effect on daily activities compared to distant vision. A specific patient population from a single country may limit generalizability of the findings. Sample size of retreated eye small. Hence, this limits the ability to detect significant differences. This makes it challenging to draw definitive conclusion of some findings. There is possibility that a small fraction of retreated patients were missed when the patient chose to undergo second procedure at another medical center. Critical appraiser includes MARI, method. It was a well-defined study with good sample size. Study population was specific patient population from a single country may limit generalizability of the finding. Study period was adequate. It was 10 years. Retrospective case study. Assignment includes specific age group requiring retreatment not studied and gender predominance requiring retreatment not specified. Assessment measure of outcome. Post-operative assessment was done subjectively and objectively. Subjective include visual disturbances if complained by the patient, and objective refraction on day 1 week, 1, 3, 6 months, and as and when needed. Results include incidence and causes of retreatment in distant targeted eyes versus near targeted eyes studied well. Incidence of retreatment for PRK eyes versus LASIK eyes not studied. Incidence of retreatment for myopic and hyperopic patients not studied separately. Interpretations include conventional monovision, dominant eye corrected for distance is carried out. Crossed monovision, dominant eye corrected for near, not done. Conventional and cross monovision was carried out in the following study of Jen. Extrapolation includes accurate patient selection is the key for good outcome. Distant targeted eyes should be corrected close to perfection for good outcome. What is our understanding is proper patient selection and clinical screening are essential for monovision success. Monovision is an effective and reasonable therapeutic modality for correcting presbyopia. Effectiveness of monovision with advancing age post-surgery needs to be studied. Most studies with a large Indian population are lacking. Thank you.
Thank you, Pratibha. And I think we welcome Dr. Praveen Vadavalli. He's joined us. So from here, so we would like to know our panelists' opinion about this article. So starting with Dr. Praveen and then to Dr. Vardhaman. Your comments about this.
Thanks a lot. Parul, can you hear me all right?
Yeah, we can hear you.
Yeah, great. I think firstly, thanks to you and Vaishal and everybody else to actually having this together, because this is one of the few reasons why we probably will read current journal articles, and probably even spending 15-20 minutes of having it broken down and presented is much better than finding those 15 minutes to read the journal articles nowadays. And I think that's true for most busy practitioners as well. So I think we should thank you both for thinking of this concept and executing it. And I think Dr. Pratibha as well very nicely presented, and I think a very good analysis of the entire article. Before, I mean, there are several things I think to discuss here. But I'll just talk about a couple of things before I come back after everybody has had their say. I think three things for me stand out here. Number one is the fact that, like Pratibha did mention, there are some deficiencies that they've not looked at, say LASIK and PRK as separate groups. They've not looked at myopia and hyperopia as separate groups, because that has connotations as well. I think in addition to that, there are potentially three other factors that will probably have a bias in evaluating the results. I think number one is the fact that if you do a monovision correction in a patient, uh, presbyopia is a dynamic phenomenon. It's not going to stay the same over time. And once they have a change in their visual requirements or in their accommodation over time, the likelihood that they'll be unsatisfied over time is also going to be a bias, because it's not a static thing like myopia that we're correcting. That's one. Second, other factors that are important as well is pupil size, because pupil size does determine quite a lot the ability to read and the ability to be able to have lesser requirement for near ad. And third is the spherical aberrations on the cornea itself, because those also, like all these presbyond and then custom Q LASIK that are being offered, they are a function of the spherical aberration. So if you increase the depth of focus, you'll probably need a lesser ad as well. So that also probably would have been good to look at from the point of view of looking at which patients require retreatment. In addition to that, there are a couple of other points that are sort of home messages, but I won't hog time right now. I think Vardhaman, and you should go next, and then I'll come back, and then we'll talk a little more later.
Dr. Vardhaman?
Yeah, thank you. And thank you again to the whole team, MOS, President Dr. Thurat sir, and the whole committee. I've been seeing that consistently. This is the fourth season, and they have been very nicely executing it time after time. Kudos to the whole team. So again, of course, a fantastic choice of the article, and I must again congratulate Dr. Pratibha. I think wonderfully presented. The analysis was excellent.
Thank you, sir.
Very, very important article, of course, and as you have rightly said, it comes from a high impact journal like JRS, and very nicely written article as well. We all know that presbyopia is possibly the holy grail of refractive surgery, and of all the other concepts that we are looking forward. I think if there is one that as all refractive surgeons would like to have more and more effective options, the one entity is presbyopia, and I think majority of the pointers about this particular article have been very nicely already told by Dr. Praveen, and I know that he himself has done a lot of work on monovision, both after cataract as well as laser refractive surgery. And so basically now coming to this particular article, of course, a fantastic article, a good choice because it is possibly the largest number of subjects ever enrolled for this kind of study, over a decade of patients with a single center. Single center also gives you probably ability to have more methodical analysis with the same kind of evaluations being done. Of course, having the multi-centric studies gives you some other, like let's say some other biases go away with that, and that always helps. I think as she has correctly said in this article, definitely there are two things which are important. Number one was that the distance corrected eye was actually requiring more correction compared to the near corrected eye. And that is not surprising because if you actually look at, and that was seen as more incidence compared to only a distance targeted for bilateral LASIK surgeries in younger groups as well for enhancement. And of course, that's not a surprise because if you look at their satisfaction when you are actually having a binocular laser procedure, which is single focus, you would actually enhance them if the patient is actually symptomatic. And most of the time, if one eye is absolutely on target and one eye is mildly out of target, 0.25, 0.5, we really actually don't go ahead and enhance them. However, if it is a single eye which is focusing for distance and it is off target, for sure the patient will be actually more, let's say, dissatisfied. And that is when you would like to go ahead and do a correction for them. So definitely no surprise that the distance corrected eyes required more enhancement. What was important standout point was that out of all the eyes which required the near eyes to be enhanced, almost 25% of them were perfect on target. Like they had actually achieved a perfect minus 1.25 to minus 1.50 an isometropia. So the patients were technically very successful, but were dissatisfied. And they are the ones who actually wanted to have a myopia reversal, right? So they again went back to their presbyopia, reversal and just correction for their distance. Again, out of the 17 eyes, 16 of them chose which were near targeted again to reverse their myopia to distance correction bilaterally. So we have to actually, of course, they have mentioned that they have done the sensory dominance test 2 times in their office. But clearly, it seems that the patient was dissatisfied in spite of probably given that kind of monovision. So does giving a longer term contact lens trial or a longer term, let's say, monovision trial helps such patients to, so that we have less number of patients who are dissatisfied is the number one question in this regard. Of course, the second thing was that were they given enough time for neuroadaptation? A very classical case I'll tell from my own experience that one patient who had undergone a modified monovision. So if you look at today's times, we are actually looking at only two approaches for presbyopia correction. One is, of course, a monovision or modified monovision, as Dr. Praveen said, which goes in the form of presbeyond or other technologies. And then you have the lens-based procedures in which you do refractive lens exchange. So one patient who had undergone a modified monovision was unhappy in the initial couple of months. Fortunately, she was not from the same state, so she was from far away. And so I had given her the option because she was constantly complaining of not being satisfied, that she can come back and I can reverse it for her. And there were two things. Number one is that she could not come back because of some personal reasons. And after about 6 to 7 months, when she came for a follow-up, we had this discussion and she chose to stay the way it is and not to go for the presbyopia or this near target reversal, because she had neuro adapted by that time and she was very, very happy. And of course, she understood that she actually goes for distance correction in both eyes. She is going to lose the ability to read up close. So they have to also understand that aspect as well. And I think as Dr. Praveen has told that, of course, the bias of not comparing the LASIK eyes versus the PRK eyes and the pre-operative myopia, hyperopia, or pre-operative emmetropic presbyopes are going to behave very differently. So if you look at those patients who are bang on target but are unhappy, typically are the ones which are very close to emmetropia, and you are actually making them, let's say, a micro mono vision patients. And of course, in terms of the future studies, if we can have a good prospective study in the way in which we can have probably a monovision, two groups, monovision with extended trial versus the monovision which were given only office-based trial, and to look at their satisfactibility of requirement of near vision reversal, along with, of course, patient questionnaire and other quality of life questionnaire indices will come handy. I think one thing which we have seen is that 36 years to 60 years is the age group that we have seen. And we all know that maybe after 50 odd years, as again Dr. Praveen had said, that your presbyopia is going to be probably quite significant, so that many of these patients may not be too satisfied with what they gain in near vision. And many patients who already are in Indian context, maybe 50, 55, have some nuclear changes. Typically, we look at these patients with eye tracy to look at the DLI to understand if they already have some internal lens component. And if these patients are probably chosen for the refractive lens exchange kind of procedures, may be more happy compared to just going for micro monovision. And the reason that they have told is actually very unusual, because they have said that they don't choose to do refractive lens exchange because of the billing issues in Israel. And that is something that is, I think, that is a bias here again in this article, because they can't really compare this to age groups that well. And of course, as we have said, because it is single country specific, of course, the population is going to have similar, let's say, pupil sizes and other things. Like if you actually try and extrapolate into other ethnicities, like in Indian subcontinent or others, we have a smaller pupil size compared to the other, let's say, Caucasian age group. So does it actually play differently in Indian patients compared to the other patients also looks to be seen. But I think, yeah, very nice article overall and very nicely discussed by Dr. Pratibha. If there are more, I think Dr. Praveen would like to add some more pointers. And I would like to also ask him, because he does a lot of monovision in cataract as well, that how has been his experience with the monovision with cataract in his group of patients. Yeah.
I think we'll probably go around the room and get opinions from others, and then we'll probably come back if that's all right.
Thank you, sir. Praveen sir and Rahman sir. Since Sen sir has joined, we'll take his.
Then we can't hear you properly.
And we can take Sen Gupta sir's inputs.
He was supposed to join after 9:30. He's not joined, I
Oh, no,
think.
he's here. He's here.
He's here.
Hi everyone, good evening, and sorry to be a little bit late to the party, but from so I don't do any refractive surgeries, of course. I'll talk from a purely statistical point of view. A couple of things. One is, the sample size really is only 47 in the study. The sample size is not 1800 or 3000, because the people, we are actually trying to describe only those who had, problematic and required resurgery. So the actual sample size is only 47. So don't get fooled by the numbers of, 3600 and all of that. One second thing is, the study period is from 2012 to 2022. So a lot of protocol changes happen, and companies are constantly improving, trying to improve their accuracy over the long run, right? So over a period of time, these protocols are going to make things better and better. So we don't know whether these errors were more towards 2012 or more towards 2022. Also they might have done some different numbers in these periods. So, so whenever you're looking at such time trends, it makes sense to divide it into quartiles, say, 4 equal groups at 2.5 years each, and then look at your, results in each of these quartiles. So were there more errors in one of those, or were it equally divided? Or perhaps, did these errors start going down over time which really shows that accuracy of these protocols have changed. So that is something that could also be looked at. Overall, it's it's a relatively simplistic study with not much analytics possible. They have come up with an odds ratio of 2.4, so that's 2.5, more than twice the chance of errors when you're doing monovision. But then when you look at the absolute numbers, it's just 47. So overall, the error rate is still quite minimal. Lastly, they have not looked at anything related to time. So when were these resurgeries done? Within a week, within a month, within a year, how was this? So I think that is very important, and they have not at all taken into consideration the just a yes and no variable. Was retreatment done? Yes, no. But then always, for those budding, always think about whether time is important to this outcome. So here maybe time is important, where if you do a resurgery after 6 months, it means differently, right? If you do a resurgery within a week to 10 days, it actually means differently, right? So that there is an error. So we are actually assuming that perhaps all of these were done within a short period of time, but then they have not mentioned anything of that, right? So I think time is something that they should have come up with. And lastly, I think the discussion is over, where age group wise comparisons are perhaps difficult to do, because those nuclear changes are more in 50 plus. So I think Vardhaman has already talked about that. So overall the numbers, I mean, the sample size is small. This is a simplistic study which is just descriptive, and time has not been taken into consideration, and trends over time have also not been shown to us. So some of the points, though it's limited from a statistics point of view, I thought these are some of the things that you could think about when you're designing your own retrospective studies in the future. Thank you.
Thank you, sir. So, we'll come back to the study in a bit. Since we are talking about monovision, I request the panelists, Praveen sir and Vardhaman sir, to just tell us in your individual practice, how exactly you go about doing monovision. How do you treat your presbyopic LASIK patients? Very roughly, right from the OPD part up to the surgical planning. If roughly you can explain, do you just do pure monovision, or do you play around with spherical aberration also?
I'll go first
Yes, sir.
briefly, if that's all right, Vardhaman.
Yeah.
Uh, I think we'll talk a little bit about monovision LASIK surgery, and then maybe a little bit about cataract later on if required. Uh, I think it's not as simplistic as saying that you will plan a monovision surgery for a particular person, because I think a lot of shared time about understanding their needs is required. And one of the most valuable lessons that I've learned in monovision correction, obviously you've heard about the contact lens monovision trial. Uh, can you hear me all right?
Yeah, yeah.
Yes, sir.
Yeah, about the contact lens monovision trial. And I think, like was mentioned in the article, about an in-office trial, but actually a patient probably is not in his or her natural environment to understand what are the implications of monovision. And monovision is not something that happens or can be assessed in like an hour or a couple of hours. So probably the best thing to do if you want to do a monovision contact lens trial is to give the patient a couple of pairs of lenses. One eye you correct for distance. In the second eye that you decide that you want to do a near correction, give them an option of two lenses, sometimes even three lenses, for them to play around with, wear on different days, spend about a week or so trying out all of these, then come back to you and tell you what is it that they like the best. Because different scenarios will require different kinds of monovision. A well-lit room with relatively larger font is very different from a poorly lit room with smaller font. Screens will require a different kind of quality of monovision. So I think if you can do an out-of-office trial, that actually is much more predictable from the point of view of what the patient will like. Second point is about playing around with Q values and also using custom Q. We have the Allegretto platform. So we tried custom Q for a while, but I'll be honest, it didn't seem to be as predictable as is claimed by the company. And I think even now they are not very keen on promoting custom Q corrections as well. Primarily because if you try and play around with the Q value, the resultant spherical error that you will induce is not predictable. And a lot of times you'll have to go back and do a tweak or correction for that, which is why I don't do custom Q anymore. I do pure monovision. Most of the times, the sweet spot for monovision is about 1.25 to 1.5, as in this article. Any lower or any higher, it either doesn't last for very long, or it is too difficult to actually merge the eyes. The other two or three important things that I think I learned with time is also make sure that you don't do a monovision correction if you have any indication that a patient is not going to 20/20 in one of the eyes. Because if there is at least partial amblyopia in one eye for whatever reason, the ability to fuse an image at near is compromised. I think the stereopsis is not very good. And if you worsen that, giving them monovision, they'll usually be very unhappy. So I think that's the other lesson that I learned over time. And I think thirdly, with monovision, if possible, it's easier to tweak monovision. Realize that your patients will likely need a second correction either after some time or after several years. It's easier to do a repeat correction in a LASIK than in a PRK. It's more for a repeat correction. So if possible, try and do a LASIK over a PRK, other than the fact that if corneal thickness determines otherwise.
Dr. Praveen, I just wanted to ask, you said that you do a monovision of minus 1.25 to minus 1.5. So is it for all age group that you're looking at? Because usually for those who are more than 50, they demand a higher near vision correction, and they are really not very happy when you are doing this amount of near correction. So do you change your correction based on the age group or maintain the same?
So I think two aspects to that question. If the patient is a myopic presbyope or a emmetropic presbyope or a hypermetropic presbyope, will also determine that. Generally, hyperopic presbyopes are happier with even a small amount of monovision because they've not really experienced good distance or near vision over time. They're usually the easiest patients to please. Myopic monovision patients are the most difficult to please. So you've got to be really careful about the target that you set for yourself. Emmetropic monovision, give them as much time as possible to go through a contact lens trial so that they understand the concept of monovision. Otherwise, they'll come back to you for resurgery. The quantum, I think, is defined by the requirements of the patient. More than 1.5, I think the difference in image size is going to play a role in stereopsis. So I think that again is a bit of a gray zone. So the ideal monovision patient probably is between 45 and 55. Any less than 45, they have not experienced the pain of presbyopia to be able to go through the time that is required for fusion for monovision. Any more than 55, they probably are falling in the range for cataract surgery. So 45 to 55 is a sweet spot.
Thank you.
Vardhaman sir, your opinion on how you go about doing monovision?
Perfect. So I think whatever, like we have probably had all the pointers from Dr. Praveen already on the same, but I think what probably I would like to add is that if one has access to if you are dealing with presbyopic patients and if one has access to the eye tracy, I think that is going to probably add to probably make your decision simpler, especially if you're dealing with patients who are beyond 50 and at that age between 50 to 55, because beyond 55 probably may not be a great idea anyway to go for monovision. Again, I never go beyond 1.25 to 1.5, even in people who are about 50 or more, because they have to understand that we are trying to give them what I tell them at that age is that we are trying to give you social independence. We are not trying to give you professional independence from the reading glasses. So as long as they are happy whenever they are in a social circle, they don't want to carry glasses with them, and they want to increase the font size of their mobile phone to a certain degree and are able to have a functionally good vision at that age, they are usually very, very happy as long as you set the right expectations. I think in presbyopia, one of the major, let's say, the pearls of success is setting the right expectations. If you spend chair time with your patients and set the right expectations without over promising anything, of course discussing about the possibilities of future progression of presbyopia, future possibilities of further enhancement for both near as well as the distance target if it is required, is going to be very, very crucial in these patients. And of course, I think about the contact lens trial, possibly is the best way to, because of two reasons. Number one is, of course, that you can't live their life. Like when they are in the office, you probably try to understand how is their lifestyle, but you can't live their life. So they are the ones who would actually go around in their day-to-day life to understand what they need. If you give them a contact lens trial for extended time, a week or two, they will definitely understand whether they are really truly happy or not. Because there are some people who will come back and they will say, "Okay, doc, I was absolutely not very comfortable with this whole thing, and you should not touch these patients." Probably you can talk to them just to do the distance correction if they are ametropic. I mean, they are having myopia or hyperopia, and they are very happy with that as long as they understand now they are not a great candidate for monovision, and they are happy to use also reading glasses. But if they come back and they say that I was very happy, I could do majority of my task without the need of glasses or contact, or I mean, so I felt like I'm independent, I was very comfortable. Definitely you can go ahead and you are very, very sure that they are going to do very, very well with this. So I think giving them the chance of contact lens trial is a great option. Second thing is that in this process, because many people, they come to you, they feel very motivated, but we don't really know how truly motivated they are. If you give them this trial and send them for a week or two and they still come back to you, so that means that they are truly motivated and they are ready to give that extra time if required for new adaptation and stuff like that. So that is important. Again, of course, that is the age group where you will have more dry eye. So again, you have to make sure that you talk to the patient about this, that of course there will be an increase in dry eye. Again, coming to the new platforms like Smile, not a great idea in patients who are having more than 40 years of age, because now a recent study by both George Aliu and group has shown that the Smile overall is known to, let's say, give a even slower recovery in patients who are in the late 35 beyond age. So patients who are at that age, typically, I don't prefer to go for Smile platform. Then, of course, as it was discussed, it is best to go for either a topo-guided femtolasic or a femtolasic procedure where you are making a flap, because enhancement becomes very easy in the future if you do that. Yeah, but generally, I think setting the right expectations, if possible, in select patients, giving a long-term trial with the contact lenses. Although I've never tried giving them 2 or 3 pairs, as Dr. Praveen has said, because I typically go for the target of 1.25 or 1.5, irrespective of the age. But I think that seems like a good thing to add for those particular patients who are probably very active in different distances, lifestyle, for example. Yeah, I think that is probably something I would.
Vardhaman, would you offer it to a very high myope with 20/20 vision in both the eyes? A concept of monovision.
Yeah, so basically, a person who is a very high myope will have an extremely strong near vision. So I think, again, spending more chair time with the patient is really required, because these are the patients who may be in the zone of being potentially dissatisfied with anything that you do in terms of their near vision. But if you, again, give them a contact lens trial for extended time, they understand what they're getting into. I think the whole thing is that they should know what to expect. As long as they understand it beforehand rather than after the procedure, I think you have a happy patient.
Yeah, thanks.
Dr. Bhakti would like to ask some questions.
Hello, I would firstly like to thank BOE and MOS for giving us an opportunity to present here. It was a very good article and it was a learning experience for us to go through this. I have a set of questions for the panelists. Most of them have been covered in the discussion part. I would just like to take up a few. In this particular article, conventional approach for monovision is implemented. That is, dominant eye is corrected for distance. However, we came across another reference article by Jain et al., where approach of crossed monovision, that is, dominant eye is corrected for near, is carried out. Any insights on this, and based on what is this decision made?
Dr. Praveen?
I think if you look at the concept of monovision is has been reported that only about 60% of the eyes in the in-clinic test. And what is the best test to assess monovision as well? We generally tend to use the in-clinic test to assess sensory dominance. It's only about 60% accurate, apparently. So you might actually go wrong in 40% of the cases. So selecting the eye that is primarily for distance, if you want to do a full correction for monovision, you will still go wrong in 40%. So which is probably the reason why crossed monovision also works. So not an exact science, which is why a contact lens trial is so valuable before surgery.
Correct. Right. Right. So then how long do we wait before considering a retreatment? And is there any particular criteria for which you consider a retreatment?
The only criteria for retreatment is an unhappy patient. There is no other
Okay.
criteria.
Okay. Okay.
That's true. I think for me, if it is distance target, if it requires retreatment, so of course it has to be done. If the eye looks stable for 3 to 6 months time, of course it has to be taken up. But if the patient is not very happy for the near target, I probably would spare more chair time with the patient and give him or her more time to probably adapt to this anisometropia, because some people would actually take longer time to adapt to it. And distance target, if you have a residual refractive error or a induced astigmatism or any other reason, I think the distance has to be corrected for sure. So that is something where probably as soon as the patient is stable, you should take it up and do it. Fortunately, with current platforms, actually, it is very, very uncommon. So yeah.
Sir, so with respect to this topic, is there anything different in the refraction you would do for a presbyopic patient? Because we need to be that much more on target. Like, would you repeat it multiple times or slightly, tend to overcorrect the myopia so that, you won't get a regression? Anything different?
I think we anyway, I mean, in our setting, I can tell that we do the this refraction 3 times for the patient. So, I mean, basically, once when we see the patient, you do, of course, we would like to do a subjective refraction. Typically, we try to do it by 2 different optometrists. If it is, of course, we in each and every patient, we do a cycloplegic refraction. And then on the day of laser, again, we would re-refract back. And if there is a discrepancy, of course, again, they are, I mean, even if there is a small discrepancy, they are looked at by one more optometrist. So basically, it is important to be on target even for like younger patients, not only for presbyopic anyway. So I think most important thing, of course, is if you are dealing with patient who has hyperopia, that you must make sure that you are actually doing a good cycloplegic refraction for the patient. That should not be missed at all. But otherwise, I think doing it in a very systematic manner, the way you would like to do for your presbyopic, I mean, your regular patients also should be done for the presbyopic patient as well. The only thing that you add on is the monovision trial with the either contact lenses or in office. But the other rest of the things almost remain the same for us.
I wanted to ask any experience of anyone about presbyopic posterior phakic IOLs.
Okay, so basically currently there are only 2 companies which are making the posterior phakic IOLs. One which started many years ago was the Care Group, and the other one is by the Star now. Unfortunately, I have a super limited experience. I've never implanted the Care Group one, and I've implanted only one by the Star. So it's very difficult to say by only that patient. But let's say that now what's happening, let's say in the late presbyopes, one of the potential benefits, if at all this technology comes to some success, one big advantage will be 2 things. Number one is that we are actually dealing with patients who are in late presbyopia, in late 50s. So of course, you are dealing with somebody who may require a cataract surgery, maybe like 5 years, 10 years down the line. And if you are actually having a patient who has a phakic lens implant, then it becomes a very smooth course, because you can always reverse it and do a very good cataract surgery and offer probably all kinds of lenses to the patient. That may not be the possibility if you're actually doing a corneal laser procedure. And of course, adding to that, less dry eye. But of course, I believe that currently the technology has not probably come to that level where we can successfully offer it to many of our patients.
Dr. Praveen, any experience with the diffractive presbyopic phakic lens with the Care Group?
No, I've never used one, Vishal. I have no idea.
Okay.
In this
Praveen, sir,
particular in this particular article,
yeah.
contrast sensitivity is affected if there is an anisopetropia of more than 2 diopters. Any inputs on this finding?
I think
more,
will be,
yeah.
Yes, Dr. Praveen, yes.
Go on, please.
No, I think, I mean, contrast sensitivity is going to be affected even if there is a micro monovision as well. But of course, what they are talking about is when it becomes probably less than what you can offer to the patient, right? So basically, if you have more than 1.5 diopter, you're going to have certain disadvantages. Like, of course, your contrast sensitivity will go down more. Second thing is, of course, your stereopsis is going to become
Go down.
significantly lesser. I think patient may not be very, very satisfied with the outcome. Yeah, so it is going to become, of course, it is going to be affected in any which way, but it will be more and more if you actually try and become more anisometric.
And if the preoperative grade of refractive error is more, does that affect the rate of retreatment? Like high myopes have more chances of retreatment requirement.
I think so. And I think one of the most important take-home messages from the article is what Dr. Zan mentioned sometime back and what Vardhaman also corroborated, that in cases that you're correcting for monovision, you got to be that extra bit more careful to ensure that you hit the target. The reason is because you don't have the luxury of leaving these patients slightly hyperopic and expecting them to accommodate because they will hate you if you do that. We are actually lucky that the average age that we do LASIK at, around 23 to 25, is much lesser than the average age at which LASIK is done, say, in a Caucasian population where their average age is, say, 36 or so. Reasons are different because here बाप का पैसा लगता है वहां पर तो अपना पैसा लगता है, so that's the difference. But the presbyopia probably also onset is a little later in irises that are lighter colored than irises that are darker colored as well, I think is the other understanding. But if you look at the article, the eye at which the near vision correction was done was not the one that required retreatment as commonly as the eye in which the distance vision correction was done. Because when you're doing a near vision correction, if you promise a patient that you're going to get -1 and you give them -1.5 instead, they're still all right. But in distance, you say that you're going to give them 0 and you give them a -0.25, they're unhappy. So the error range in the eye that you're going to leave for near vision is much lesser than the error range for the distance vision eye. And in general, the other reason why for routine distance vision LASIK correction, and the article mentioned this as well, is more forgiving, is even if you have a 0.25 error in one eye or a zero point 0.5, hopefully the other eye compensates because it has good vision. And with summation, binocular vision is generally quite good. But here, each eye is its own measure, and so you have to be that much more accurate. So that's the reason why in patients who don't have the ability to accommodate or each eye where you're going to be viewing with only one eye at a time, the importance of cycloplegic refraction and also ensuring that you're on target is very important. Because of this, higher myopes, generally the treatment time is longer and the risk of overcorrection is more with higher myopes, though you have nomograms that tend to reduce that overcorrection. But still, the higher the refractive error, the higher is the likelihood of your residual error. I'm sure all of you have known that over years as well. And they are less forgiving in the presbyopic age group than in age group who can accommodate a little bit. So that's the reason why low myopes generally offer much more predictable corrections than higher myopes do.
So to continue this discussion, would monovision be a good option or not for professions where in presbyopics, where distant vision requirement is more in presbyopic age group?
So probably drivers.
So I guess I'm not sure if I can answer that question accurately because generally, even the premise of having a dominant eye and the premise of having the dominant eye corrected for distance is that you will still have sharp distance vision. And stereopsis is not all that important at distance than it is at near. So most people generally are quite functional for distance vision. It's the near and getting the right distance that they're unhappy about, then distance vision if you hit target for one eye at least. The question in addition to that is like there are several doctors or several surgeons who desire both cataract surgery once they're a little older and also who desire refractive correction. And we have explored monovision even in these patients. But I think the difference actually occurs in what kind of surgeons they are. If they are surgeons who are using, say, a microscope where they can customize the each ocular can be custom set for their refractive error, then it probably doesn't make any difference at all. But if you have like a surgeon who is like a lap surgeon who needs good intermediate vision and also good distance vision to look at the monitor, it becomes a little bit more challenging there because you also want to get them good stereopsis. And every eye that has a difference in the refractive error or difference in the aberrations will have a drop in stereopsis, however little. And I think you got to be very careful when you operate on surgeons who have this requirement of having to see distance as well as intermediate at the same time.
So, Praveen, in your practice, how many percentage of presbyopic patients, as compared to your normal young age group? So, what percentage of presbyopic patients do you treat, or you can
I
convert?
I think it's increasing now. I think earlier it is the exception rather than the rule. Now, I think I don't know if I have a percentage. It's still a very small percentage. The biggest proportion are still the myopes, but it is increasing. More and more people are exploring presbyopia and monovision. And then this is again interesting. A lot of myopes, when they turn presbyopic, especially the higher myopes, they will be very unhappy because of the distortion that their glasses cause and also the ability to get good progressive glasses with high myopia as well. And so more and more patients at the time that they become presbyopic are opting for laser vision correction. And you can actually give them good distance vision correction and get them to use presbyopic glasses if they understand the concept of presbyopia. That actually is a very safe bet also now.
But will they not be better with clear lens exchange?
I mean,
High
these are
power.
40, 45-year-olds,
Probably
so
better.
maybe a
Yeah.
little too early.
I think I've seen the same phenomenon also in my practice because I think people who have been having moderate or high myopes, suddenly when they become presbyope, you see them that they have just got diagnosed with presbyopia 3 months back, and now they have tried the first progressive lenses glasses, and they are not very happy with that. They will come to you early, very early 40s, like they're 40, 41 years old. And I think exactly this is the one that we do. We actually talk to them about treating their distance. My preference will be treating them on target for distance and leaving them with a small pair of reading glasses. They are generally very happy with that. And I think we have had, I think, again, more and more number of patients who are coming for presbyopic corrections in this era. And again, a lot of patients are now, because now we, that with the era of this newer lenses, late 50s, a lot of people are coming to check if they have cataract because they want to get rid of it as soon as possible, along with getting rid of glasses. So these are the other group of patients who are increasing. So very, very early 40s and probably late 50s are the ones which are actually coming in more numbers. Yeah.
There are many patients who are emmetropes actually, but have presbyopia, right? They are the people who keep coming and asking for the presbyopic correction. So, have you been motivating these patients and doing the patients for a presbyopic correction in terms of monovision?
I think,
In presbyopia, the lesson that I've learned is don't motivate the patient. If the patient motivates to, then you do surgery.
yeah,
The
I think,
other question is that how much of micro monovision can be done? Because in some cases, you want to give them maneuverable vision. So even you can leave them slightly myopic instead of completely distant vision in both eyes. Then the neuroadaptation is far easier than keeping a more anisometropia.
Yeah, completely agree. And you're looking at one example of that. So when I got my TRK done, I was a high myop, right? So my plan was I didn't want too much anisometropia, and I said that, hey, if I aim for too much anisometropia, I'll have issues with stereopsis. So I left myself with plano in one eye and a 0.75 in the other eye was the plan. But I ended up with a plano and a minus 0.5, which was good for like maybe 5 years, maybe even less than that. And after that, you see me wearing reading glasses again. So it probably is great, but it lasts for a very short.
And in patients who are hyperope, so usually you see a lot of patients who have unmasked hyperopia and they want presbyopic correction. So would you go ahead and do them, or you would?
Yeah, if you do a good cyclo and if you're able to correct the hyperopia at the presbyopia, these patients are very happy actually.
Very happy, yeah. One of the happiest.
And plus they have a prolate cornea, so even the spherical aberration helps them to see.
Yeah. In
Absolutely,
fact, like
absolutely
the
true.
two set of patients that we just discussed, like the happiest will be this hyperopes who are unmasked, and the most dissatisfied will be the immetropes who became presbyopic. So it is better not to touch the immetropes. And
Very
actually, this article, that is what exactly they should have like probably discussed if they had the patients who were actually reverse for near target, whether they were actually, how many of them were immetropic presbyopes to begin with.
Yeah.
Yeah.
I think we have overshoot.
So we have had a very good discussion on monovision, and it's time to conclude. And thank you, Dr. Praveen and Dr. Vardhaman, for a brilliant talk. And I would ask Dr. Karishma Wadia to do the vote of thanks.
Dr. Praveen, I would hope that you will keep coming for our JCs.
Yeah, definitely.
Difficult to get him.
Yeah, I mean, it's fun because I think we had a great discussion today. I mean, to be honest, and very good questions as well, and great presentations as well. I think I learned a bit as well. 9 to 10 is a little challenging though, but yeah,
Yeah, I
still,
know.
We
I
had to
would love
change the
to.
time today uh, because we had a clash of timings. Otherwise, we started 8:30.
A lot of people are probably watching the T20 match as well.
Fine. Karishma, go ahead.
Good evening, everybody. I'd like to bring to your notice that I'm the e-metrope who's converting into the presbyope, and I'm terribly unhappy. so, I hope you have better solutions for me. But on that note, I'd like to thank our presenter, the moderator, our panelists. Thank you, Dr. Praveen, for joining us. Thank you, Dr. Vardhaman, for your insights. And I'd like to thank our JC committee chairman, Dr. Vaishal sir, who so enthusiastically conducts all these meetings. Dr. Parul ma'am, our chief coordinator, Dr. Sabyasachi, who's our statistical expert, Dr. Zain and Dr. Neeraj, who are the enthusiastic new coordinator and JC convener for Journal Club. So I'd also like to thank our MOS office bearers and the BOA office bearers for all the support. And thank you everyone for your participation. And this, with that, we'd like to bring this Journal Club to an end. There's Dr.
We
Veera.
thank the Entod, the official sponsor for the Journal
and
Club
thank you,
meeting.
Entod, for your never-ending support.
Absolutely. And we especially thank Dr. Viral Shah, the Secretary MOS, and Dr. Piyush Bansal, Scientific Committee Chairman MOS, for attending our JCC meeting, and Dr. Sirish Thorat for attending the meeting today.
Thank you, sir. Thank you. Especially thanks to you, Vaishal sir and Parul madam, for such a wonderful initiative and all continuing it since last 3-4 years. We are seeing it every alternate Wednesday, third or fourth Wednesday, every alternate month. And you bring such beautiful articles for review, and it goes on till 1.5 hours. So wishing you all the best. Continue the same. And thank you to Team BOA also. Thank you, Karishma, for coordinating this meeting, and Neeraj and Zaid.
Thank you. Thank you, everyone.
Thank you, everyone.
Everyone.
Thank you, Praveen. Thank you,
Thanks,
Dr.
everyone.
Good night.
Good night. Good
Night.
night.
Thank you. Thank you. Bye.